Thank you for inviting me. My talk is titled Early Psychosis and the Psychosis Risk Syndrome, Current Knowledge, Research, and Best Practices. I do not have any relevant disclosures to make. So I'll start this talk by giving a historical perspective on why our field has thought for some time that early intervention in psychosis is important. Going back now several decades, there is an accumulation of research that has shown that the longer a young person has psychotic symptoms during their first episode of psychosis that go untreated with an antipsychotic medication, the poorer the response to treatment once it's initiated, the greater likelihood of relapse and the poorer the outcome. This is just one example of that kind of study that has informed the field now for several decades, contrasting the rate of relapse in young people after a first episode of psychosis who either had a long duration of untreated psychosis of greater than a year where symptoms went on without treatment versus a shorter duration of untreated psychosis, less than a year. And you can see there's a substantial difference in the rate of relapse with the short duration of psychosis individuals remaining more likely to be free from a relapse episode. So this not only led the field to prioritize the importance of early diagnosis, early identification of young people experiencing the first episode of psychosis, it also raised the question whether we might be able to identify psychosis prior to its onset during what we would refer to in medicine as its prodromal period. So if we look at Wikipedia for a definition of prodrome, what the term prodrome means, in medicine, a prodrome is an early sign or symptom that often indicates the onset of a disease before many more diagnostically specific signs and symptoms develop. So for example, fever can be considered prodromal to measles when it first shows up. The National Institute of Mental Health has defined the psychosis prodrome as a period preceding the onset of the first florid psychotic episode when there is increasing symptomatic presentation and functional deterioration. So we have known for some time, based on retrospective reports, that psychosis onset is typically preceded by a prodromal period, most typically 1 to 2 years, during which milder forms of symptoms emerge and during which we see decline, often in work function, school function, social functioning. And that's illustrated in this slide, that, that prior to the prodrome, there may be very subtle functional deficits, but really nothing particularly pronounced or that would get attention of a clinician. But you see this decline happening preceding the first episode of psychosis. So beginning with the work of Pat McGorry in Australia, who started to ask whether formal criteria for the prodrome could be developed and validated to allow prospective identification of individuals who were at risk for psychosis by virtue of having prodromal symptoms. And they did this mostly by retrospective interviews of patients in, recovering from a first episode of psychosis and inquiring about what their lives were like, what their symptoms were like in the 1 to 2 years prior. Based on this, they came up with 3 patterns or subsyndromes that seem to be indicative of risk for psychosis. The first one, and by far the most common, is known as the attenuated psychosis symptom state. And in fact, if you read the literature on the clinical high risk syndrome, most of the patients who are studied will meet the attenuated psychosis symptom state criteria. Another way to be considered prodromal is by exhibiting what are called brief intermittent psychosis states. These are states that seem more like full-blown psychosis, but don't have the duration or persistence to meet the criteria for full-blown psychosis. And the third way to be considered at clinical high risk based on their retrospective reviews of patients' histories was having a genetic risk for schizophrenia, so having a first-degree relative with schizophrenia, or having a diagnosis of schizotypal personality disorder, which is considered to be in the genetic spectrum of schizophrenia, but also showing deterioration in function over the prior 12 months. So these three subsyndromes are not mutually exclusive. Someone can meet criteria for more than one. And this is how the Australian group set out to define these criteria and see whether they could actually validate them by looking at what happened to people over time. So one of the things that is important to convey that is, as the field started to work backward in time and see if they could identify individuals during the prodrome preceding psychosis, they also had to define when should we consider full psychosis to have developed, and that symptoms are no longer prodromal. When is the line crossed into full psychosis? So the answer that the field converged on was that first and foremost, the critical issue is what's known as conviction or delusional conviction. In the case of full psychosis, the individual believes that their experiences are true or real. They're no longer ambivalent or uncertain about the symptom being perhaps just their mind playing tricks on them or possibly true. So they have crossed the line into full conviction at least a good part of the time. There's also a requirement that the symptoms have a sufficient duration. So symptoms have to be present for at least an hour each day for 4 days per week on average over a period of months, or of 1 month rather, to be considered fully psychotic. And then there is a provision that if the symptom is sufficiently dangerous or disorganizing to the individual, including things like threatening to their livelihood, their family relationships, or their dignity, then we would consider psychosis to be present even if the duration criterion isn't met. So these are the three critical domains that I just covered in terms of defining that distinction. And these are implemented in a structured interview that has become a gold standard in the field for establishing whether a young person meets the criteria for the clinical high-risk syndrome. And I should quickly mention that this syndrome has different terms that have been used over the years to describe it. Prodrome was the first term that was used, but it's recognized that not everyone who meets these criteria will progress to full-blown illness. And therefore, the term prodrome was thought to be not appropriate because that does tend to assume that what we're seeing is the prodrome of a full-blown illness, which is not always true. It has been called the clinical high-risk syndrome or clinical high risk for psychosis syndrome. Also the psychosis risk syndrome. Sometimes it's called the ultra high risk for psychosis syndrome, UHR. Just wanted to give you a sense that all of those are referring essentially to the same thing. And I think we're starting to see some convergence now of clinical high risk as the main way that this is referred to. The SIPS remains the structured interview for psychosis risk syndromes, one of the main instruments used to establish the diagnosis. The diagnosis of the clinical high risk syndrome is essentially based on positive psychotic-like symptoms, but at a psychotic level. So there are 5 domains that are interrogated, and the interviewer is encouraged to use questions of the following kinds to give you a flavor of what kinds of symptoms are solicited. So the first domain is unusual thought content. This is kind of the general delusional, odd ideas, odd beliefs kind of category. Questions would include things like, have you ever been confused at times, whether something you've experienced is real or imaginary? Do people or surroundings ever seem strange or confusing or unreal? Or do you ever feel as if somehow thoughts are put into your head or taken away from you? Again, these are the kinds of probe questions that are asked. The second domain is suspiciousness or paranoia. Do you ever feel that you have to pay close attention to what's going on around you in order to feel safe? Do you ever feel like people might be intending to harm you? The third domain that's asked about is grandiosity. Questions include things like, have you ever behaved without regard to painful consequences? Do you ever go on excessive spending sprees that you can't afford? Do you ever think of yourself as a famous or particularly important person? The fourth domain are perceptual abnormalities or hallucination-like experiences. Questions include things like, do you ever hear unusual sounds like banging, clicking, hissing, clapping, or ringing in your ears? Do you seem to feel more sensitive to light, or do things that you see ever appear different in color, brightness, or dullness, or have they changed in some other way? Finally, the fifth domain, and there are five, that's inquired about to establish the diagnosis is disorganized communication. So questions about that are, do people ever tell you that they can't understand you? Do people ever seem to have difficulty understanding you? Are you aware of any ongoing difficulties getting your point across or finding yourself rambling or going off track? And then also this rating is based on the participants' thought process during the interview. Each of these symptom domains, and they're labeled P1 through P5 for the positive symptoms, is rated on a 6-point scale by the rater, where the 6 rating is considered fully psychotic and not meeting clinical high-risk criteria because they've crossed the threshold. The 3 through 5 range, moderate to severe but not psychotic, is what's considered the clinical high-risk range. And then the 0 to 2 range is considered subthreshold even for clinical high risk and not significant clinically, not meeting clinical high risk criteria. The SIPS does provide anchors for each of these ratings to help the rater make the distinctions here. And I think it's useful when I give this talk to give an example. In this case, it's suspiciousness and persecutory ideas, to read what the anchors say for a 5, which is the highest end of the prodromal or clinical high risk range, versus a 6, which is what has, it would be considered severe and fully psychotic. So a 5 on this domain of symptoms includes loosely organized beliefs about danger or hostile intention. Skepticism and perspective can be elicited with non-confirming evidence or opinion, and their behavior may be affected to some degree. There may be a guarded presentation that may interfere with their ability to get, your ability as the rater to gather information in the interview. That's all high end of the high risk range. A 6, in contrast, is considered present when there's delusional paranoid conviction with no doubt, at least intermittently for periods of significant periods of time, and that these symptoms are likely to affect functioning. So I like at this point just to give a few examples of cases that kind of capture the range. So this is one example of Annalisa, a 14-year-old who had a diagnosis of attention deficit hyperactivity disorder since age 6. She's always had trouble concentrating on schoolwork, but her classes now seem more difficult for her this year. She has several friends and she enjoys extracurricular activities. This is somebody who would clearly not be considered in the clinical high risk range and wouldn't expect that a referral to a program like ours would be appropriate. Here's a second example. This is Neil. He's a 16-year-old. He's a B grade student with attention problems this past year. He has had recent difficulty staying on track during conversations, and a teacher has described him as odd and sometimes difficult to follow their comments in class. So in this case, this is a possible clinical high-risk referral, somebody who may be struggling with disorganization of thought process and might warrant further systematic evaluation with a SIPS interview. Here's a third person, Sarah, 15 years old, reports lifelong mild anxiety, recent panic attacks. She appears guarded and reports no close friends. She worries that classmates might be planning to hurt her, but she doesn't know why, and she does hear whispers at night for the last 3 months. And this would be an example of someone who may meet clinical high risk criteria, would certainly be an appropriate referral if someone was wondering, might this person be considered clinical high risk? And the final example here is of Kai, a 19-year-old male who described several years of mild depression. He started hearing a voice in his head saying negative words like dead and filth in the last year, and he thinks it may be his old roommate who moved to Los Angeles, and he's recently worried that his arm doesn't work anymore correctly and it feels like he can't control it. And this would be an example of symptoms that would most likely fit with the first episode of full psychosis. And we say both of them would be appropriate referrals in the sense that our program offers care for individuals across this range. So what do we know about the validation of these clinical high-risk criteria and the likelihood of transition to psychosis? Well, one trend I'll just mention is that in the earliest studies that were done in Australia, the conversion rate to psychosis over a 2-year period was close to 40 to 50% of individuals who met the criteria. Over the 2 decades since that first work was published, though, we've seen the clinical high-risk conversion rate to full psychosis decreasing. We think it's probably because we're getting more referrals from less severe patients in our programs, as more people have become aware of sort of sub-threshold psychotic symptoms. Our best estimates now, and this comes from a meta-analysis that was published in 2021, is that at around 2 years of follow-up from initial diagnosis of the clinical high-risk syndrome, there's about a 19% risk of transition to psychosis over 2 years. And that starts to flatten out as you go further in time, so that by 4 years, as is shown in this bottom left plot, the conversion rate ends up being around 26%. And in the plot on the right, you see actually, based on all the meta-analytic data across studies they have available, estimates of conversion rates going all the way out to 10 years from the initial clinical high-risk diagnosis that suggest conversion rates are around 35% within a 10-year period. You can see with the blue line on the right that, which is a hazard risk plotted over time, that the risk for developing full psychosis is greatest in the first 1 to 2 years after the clinical high risk diagnosis, and goes down substantially after that. So from years about year 4 through year 10 from these data, the risk is relatively low, and you see very slight increases in the conversion, cumulative conversion, at kind of asymptotes at that point. Of those who convert to psychosis, about 2/3 of them meet the criteria for schizophrenia or schizoaffective disorder. And about 1/3 meet the criteria for another type of psychotic disorder, typically a mood disorder like bipolar disorder, or in some cases, drug-induced psychoses or psychoses related to other conditions. I also wanted to make sure that people knew that the clinical high-risk criteria do appear now in the DSM-5, in particular under the other specified schizophrenia spectrum and other psychotic disorders category. It is known as the attenuated psychosis syndrome. And these criteria are essentially recapitulation of the criteria that are embedded in the SIPS interview that we just discussed. So I want to talk a little bit now about some of the research that's been done with individuals who meet these clinical high-risk criteria. One of the major studies that have been done in the world to this point is known as the Naples study, or the North American Psychosis Risk or Prodrome Longitudinal Study. This involved some 9 sites around North America, including our site at UCSF. And one of the things I want to highlight about the Naples study, consistent with what I just showed you from the meta-analysis, is that in the Naples study, where we had some 700 to 750 or so clinical high-risk individuals recruited over all of the Naples sites, there was a conversion rate of about 18% over a 2.5-year follow-up period. And at 1 year, it was about a 13% conversion rate, not the 35% that we see in some of the early studies or that when you go out to 10 years. However, when we focus just on the first 2 domains, unusual thought content and suspiciousness and persecutory ideas, and focused on individuals who met prodromal level criteria for just those 2 items, we saw that the conversion rate was higher, that it approached 41% of those individuals over a 2.5-year follow-up period. And that's important because there still is a subset who may be at higher risk when we consider some of the specific symptoms rather than the overall clinical high-risk diagnosis. In the Naples study, we also did a fine-grained analysis of the individual symptoms that are assessed by the SIPS. The SIPS does assess those 5 positive or psychotic symptom domains, as I mentioned. It also assesses negative symptoms and mood symptoms, depression-type symptoms, although it does not use them in making the clinical high-risk diagnosis. But they are assessed and rated on severity scales. This analysis that I'm showing actually shows how the SIPS symptoms ranked in terms of their contributions to predicting conversion to psychosis, using a fairly rigorous cross-validation routine to zero in on more robust findings of prediction. And what I want to highlight is that the first 2 items are the strongest predictors. They include, number 1, severity of suspiciousness and persecutory ideas, so the P2 item, and then the P1 item is next, the unusual thought content, unusual ideas. The third is actually ideational richness. It's a negative symptom, so it's actually the lack of ideational richness that seems to be predictive, but not actually included in the criteria for clinical high risk because it's not considered to be specific enough. The other thing I think is very important from this work is that where do hallucinations fall in terms of their predictive utility? They're way down here, they're 4th from the bottom. So what we've learned from this is that the severity of hallucinatory type experiences is not a very good predictor of the likelihood of progressing to full psychosis and losing insight. And it is something that we are now more mindful of, that patients may experience hallucinations but retain insight, that this is just their mind playing tricks on them, that they don't believe they're real. And there may not be a strong basis for starting an antipsychotic just because somebody is having hallucinatory type experiences if they retain insight about those experiences, because the likelihood of future transition into a full-blown psychosis is not very well predicted from the severity of those hallucinatory experiences. The Naples 2 study also put together a proposed risk calculator that included measures that were measured in the Naples 2 study, but was based on the prior literature. So we didn't look at data in the Naples 2 study. We chose based on prior studies that had shown promising predictors of conversion to psychosis, and they included the SIPS P1 and P2 items, decline in social role functioning, Hopkins verbal learning test. This is a cognitive test, as well as the back symbol coding test and other attention-based cognitive tests. Age, stressful life events, family history of psychosis, and history of traumas were all candidates that were proposed for a risk calculator. And it turned out that the history of family history of psychosis, stressful life events, and the history of traumas did not significantly contribute to the risk calculator predictions. The other items did make more significant contributions, particularly the top 3 or so. And overall, the study showed that we achieved about a 0.66 or 0.7 area under the curve for predicting the transition to psychosis. Based on those 8 items, we get a risk score. And this shows the distribution of risk scores in the Naples clinical high risk sample. The orange group represents those who did end up transitioning to psychosis, and the green, those who were non-converters over the course of the study. So you can see that there is some separation, but also some overlap. The paper that describes the Naples 2 risk calculator also has a link to an online website that has this risk calculator available. If a site has the ability to assess these domains and expertise to do the cognitive assessments and to implement some of the other scales, they can actually go in, put in the scores for an individual, and get a 1-year and 2-year estimated risk for transition to psychosis, which can be helpful in working with young people and their families, helping them to try to put some perspective on their level of risk and have monitoring and treatment decisions that kind of match to where their level of risk is. The Naples risk calculator has now been replicated in independent samples at least 4 different times and shown to have really good and similar predictive utility compared to the Naples 2 study, where it was really not derived, but first tested for significance. So I want to turn to talk a little bit about what we know about treatment for clinical high risk and for first episode psychosis. So I'll start again with something that we've known in the field for a while, which is that the studies showing that longer duration of untreated psychosis are associated with poor treatment responses and poor outcomes supports a risk-benefit analysis that suggests that early diagnosis of psychosis and early introduction of antipsychotic medication as soon as psychosis is fully present is a good idea, that is a way to try to mitigate some of the risk of poor treatment response and poor outcomes. And it is the basis for some of the work that the NIH did in testing and validating the usefulness of what are known as coordinated specialty care programs. The first major study of this is known as the RAISE study for first episode psychosis that did demonstrate that they were able to reduce the duration of untreated psychosis by having these programs set up, and that also was associated with reductions in social isolation, increased employment success, decreased homelessness, improvements in quality of life. However, when it comes to clinical trials that have been done in the clinical high-risk syndrome, the evidence is not so strong in terms of the benefits of treatment. And in particular, I just want to mention that there have been a handful of medication trials with antipsychotics that were placebo-controlled, double-blinded trials. These studies really proceeded with the hope that if they treated these clinical high-risk sub-threshold symptoms with an antipsychotic for an extended period, like 6 months or a year, and then stopped, that they would have effectively put out the kindling fire of a pending or impending psychosis, and that individuals would now be free to no longer be at risk and be able to have avoided the risk of psychosis. That turned out not to be the case. So the studies that were done did show some improvement in the psychotic-like positive symptoms while the medication was on board relative to placebo. But as soon as the medication was stopped and then patients were continued to be followed, we saw that the transition to psychosis became the same in the placebo group and the active group. So there was no real benefit of early introduction of antipsychotic treatment prior to the onset of psychosis. And in fact, what we learned, of course, in those studies is that there were a lot of side effects introduced by the antipsychotics. And certainly young people are not immune from that. So based on what we know, that fully 80% of individuals who meet the clinical high risk criteria based on the SIPS interview are not likely to develop a psychotic disorders within 2 years. And in fact, we know that 30 to 40% of young people who meet the clinical high risk criteria will actually experience a complete remission of these symptoms over a 2-year period. And another 30 to 40% will continue to have symptoms in this kind of clinical high risk range without progressively worsening to full psychosis. Based on that, the risk-benefit ratio does not clearly support treatment with antipsychotic medication for the clinical high-risk syndrome. Again, the medications may alleviate symptoms and distress, and sometimes we do need to make that decision for individual patients. There is no evidence that introducing the medication can prevent psychosis, and the risks of these medications, including weight gain, sedation, risk of developing tardive dyskinesia, probably outweigh the benefits when considering whether to initiate this kind of treatment at this stage. Further, antipsychotics introduced in the clinical high-risk stage can really obscure the diagnostic and prognostic assessments. It becomes very unclear what we're treating, whether it's really full psychosis now that actually is getting masked by the treatment. We don't know how long we should be recommending treatment. And so it can really muddy water without a clear benefit. And so the current recommendations are mainly clinical monitoring and using caution when considering antipsychotic medications, and making a risk-benefit analysis for each individual and engaging them in decision-making, knowing that it's not a standard of care to introduce antipsychotics at this stage. This slide just is a summary of some of the major groups around the world and their recommendations, treatment recommendations for the clinical high-risk syndrome. None of them recommend starting antipsychotic medication at the clinical high-risk stage. So another question that comes up in connection with the clinical high-risk syndrome is whether the brain abnormalities that we have seen after decades of research with patients with schizophrenia, whether they're also present during the clinical high-risk syndrome prior to the onset of psychosis. So the prevailing hypothesis of schizophrenia is that it's a neurodevelopmental disorder, and that would predict that brain abnormalities associated with schizophrenia probably arise during neurodevelopment before the onset of psychosis. However, many of the brain abnormalities that we see in schizophrenia could have been in the phenotypes that just reflect the genetic vulnerability to develop the disorder. Both of these views would predict that you would see these abnormalities in clinical high-risk individuals prior to psychosis onset. But we don't know whether some of the neurobiological abnormalities may emerge or worsen during the transition from the high-risk state to full psychosis. And this is something the field really wants to understand in terms of mechanisms of psychosis and transition to psychosis. So this has spawned a major area of work to identify and test biomarkers already shown to be sensitive to schizophrenia to see whether they can be used to improve our ability to accurately predict who's at greatest risk for psychosis in individuals with the high-risk syndrome. So I want to share some of the work and research that's been done to try to improve the accuracy of risk prediction by considering domains. I'm going to talk briefly just about cognitive, genetic, and other biological measures. And the hope here is that with greater prediction accuracy by considering some of these biomarkers and other measures, that we can tip the risk-benefit ratio in favor of early intervention, even with more aggressive interventions, and being able to target those interventions to those who are really at the greatest risk. So one of the domains I wanted to just share with you, and this is another meta-analysis because there are enough studies done, document that individuals at clinical high risk for psychosis have cognitive impairments relative to healthy individuals. So cognitive deficits are present prior to the onset of full psychosis. And we know from the Naples study that those who are destined to convert to psychosis, and they are shown in these kind of light blue circles in this plot, have greater deficits in cognition at baseline. And this shows attention, working memory, and declarative memory abilities in particular to be affected. They have greater deficits than both the clinical high-risk individuals who do not progress to full psychosis and greater deficits in healthy individuals. So cognitive impairments can be a risk factor indicating greater risk for transition to psychosis. The Naples study also considered polygenic risk scores for schizophrenia. You may know that the field has identified now up to several hundred risk genes for schizophrenia that have survived multiple comparison corrections and have allowed for the field to be able to calculate what are known as polygenic risk scores based on the accumulation of how many of these genes does a person have that puts them on the risk side. Looking at whether polygenic risk scores are greater in clinical high-risk individuals who go on to convert to psychosis. They are. You can see this on the, they are in the group in the far left. The polygenic risk scores are shown on the y-axis. They are slightly elevated in the converters relative to the middle group, the non-converters, and the far right group, the healthy individuals. This is done separately for people with European versus non-European ancestry because that's important to do in genetic studies. But I think the main thing to get across is it's a very small effect, so that actually we don't see a significant enhancement of prediction by considering polygenic risk scores for schizophrenia. It means that most of the clinical risk predictor data that we use in the risk calculator, for example, overlaps with information that comes from the polygenic risk score, genetic risk. So some of that information is redundant. The genetic risk information doesn't add very much to the clinical risk data, is one of the key findings there. Just a couple of other highlights of other biological abnormalities or neurobiological abnormalities. This is an EEG, scalp-recorded EEG-based test looking at the brain's response to auditory deviant sounds that are presented in a stream of standard sounds, so something like beep, 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 and having subjects ignore the sounds. So this is something that the brain pays attention to even when subjects don't pay attention to it. It generates a negative wave known as the mismatch negativity, well known to be reduced in schizophrenia. And what we have shown is that it is reduced also in CHR individuals who go on to convert to psychosis relative to those who do not. A similar paradigm, but this time involving attention to a deviant sound, kind of like similar to the previous one, but now participants have to press a button when they hear a deviant sound, and this generates a positive wave known as the P300 from the scalp EEG. And this shows the scalp topography maps. That big red positivity is where it's measured, located on the scalp. And I think what you can see here from the waveforms is actually we have some effects, but it's mainly in predicting which clinical high risk or psychosis risk syndrome individuals are most likely to remit from the syndrome. You can see that those who are likely to get better and have their symptoms go away and no longer meet criteria look just like the healthy controls in their waveforms and in their topography maps. Whereas those who are destined to convert to psychosis or to remain symptomatic show this reduction in the P300 at baseline that doesn't really differentiate between them. And finally, I just want to note that the Naples study has also used MRI scans to study what kind of brain changes happen in those who transition to psychosis. One of the things that you see is that there's a loss of gray matter in the prefrontal cortex in over a 1-year period in those clinical high-risk individuals who convert to psychosis relative to healthy individuals, that's shown in the left column, and relative to clinical high risk who don't convert to psychosis, that's shown in the third column down. And that led to a follow-up study in what's known as the Naples 3 study, where we did much more fine-grained MRI assessments every 2 months for the first 8 months to see whether we could capture this change earlier. And what this paper is now in press, what we have found is that we can detect loss of gray matter in those regions that are shown in that map in the blue spots in the cortex. We can detect that rate of decline in future converters, those at high risk who are destined to convert. They show a steeper rate of decline. Even at 2 months, we can detect that, that change as significant from the non-converters and from the healthy controls. So it seems like there's information in the dynamic changes in brain structure that may be useful in forecasting clinical outcomes. And this may be consistent with pathophysiological mechanisms that are thought to be involved in the transition to psychosis, like over-pruning of cortical synapses at a time when pruning is happening during brain development. So I'm going to just switch gears now to talk about where is the field in terms of current research with the clinical high-risk syndrome. And I wanted to, in particular, tell you all about a major initiative that the NIH and the Foundation for the NIH, or FNIH, has funded. The Foundation for the NIH is an entity that exists. It's a sister entity to the National Institute of Health, but it's a private foundation that can work with industry partners very easily to channel money into efforts where industry and the NIH collaborate. And this is a partnership that's known as an Accelerating Medicines Partnership, or AMP. The NIH has partnered with industry and drug companies through the FNIH to make advances in novel development of novel treatments for disorders like Parkinson's, Alzheimer's, diabetes, cancer. But they've never had an AMP initiative funded for a psychiatric condition until now. And this partnership is known as the Accelerating Medicines Partnership for Schizophrenia, or AMP-SCITS. Although its focus is not on schizophrenia, it's really on the clinical high-risk syndrome. And what has been funded are 2 major networks. One of them is known as ProNet. ProNet has 26 sites around the world, including our site at San Francisco. And there is a second network that's based in Australia, has another 11 sites. So together we're at about 38 sites between the 2 networks. And we're all working together to accrue a sample of 2,000 clinical high-risk individuals who are going to be assessed with an identical protocol across all 26 sites around the world, including clinical interviews and biomarker assessments that are going to be done at baseline, shown as month 0 here, as well as at 2 months. That includes MRI, EEG, cognitive testing, and we are doing some novel measurements, including wristwatch actigraphy measures and phone measures to get at real-time surveys and things like that. Individuals cannot have had greater than 50 milligrams lifetime exposure to Haldol or equivalent to be eligible. The age range is 12 to 30. We do get MRI scans read by neuroradiologists, so it's one way to get a free MRI scan. And we can also put together neuropsychological reports based on the cognitive neuropsych assessments that are done. These are just some of the benefits. Participants can earn as much as $2,500 participating in the full study, including the phone and actigraphy rating measures. And if they don't do that, as much as $1,800. I know we're just about out of time. I'm going to quickly just cut to the end here. We also have a second study that is a family therapy study focused on clinical high risk. 2 different versions of family therapy are being tested there. That's still actively recruiting. And we often just like to remind people about the benefits of doing research, including helping to advance our knowledge about early psychosis, getting feedback about worrisome experiences that can be also shared with family or clinicians that are taking care of participants. We can get MRI reports and cognitive reports. People do get paid. And these assessments are free, especially an issue for people who don't have insurance and may not otherwise be able to come to a place like UCSF. Our Path program, we are integrated with our research program, but we do a lot of treatment for people who aren't in our research. We do med management, expert diagnostic assessment, psychotherapy, family education and support, and case management. We serve people 35 years or younger, and anywhere in the spectrum from clinical high risk to psychosis to recovering from a first episode of psychosis. We have child psychiatrists on our team as well. I'll stop at this point, just leave this up with our contact information, including our phone number, email address, where you can write to us with referrals or questions, and note that we are now in our new location in the Pritzker building in Mission Bay in the new psychiatry building. So with 4 minutes maybe to spare, I'll stop and answer any questions.